Hi, everyone, and thank you for joining us. I'm pleased to introduce Kathryn Mulligan. Kathryn is a clinical nurse specialist for New South Wales Anaphylaxis Education, who is here today to share her knowledge and some strategies in managing anaphylaxis in family daycare services. A very warm welcome and thank you for joining us today, Kath.
Thank you for having me.
My name is Rachel and I'm joining you from Gadigal country. Can I ask where you're joining us from today?
I have the pleasure of joining you from Guerin country.
Wonderful. So, Kath, to start off, do we know why some children develop allergies? And do you think we're seeing an increase in diagnosis?
So there is definitely an increase in allergies. It's not a case of they've been around all the time and it's just that we're seeing it more. There is actually definitely an increase in the incidence, and it's increased since probably the late 90s. So we know that about 1 in 10 one-year-olds has diagnosed food allergy. So that's 10% of one-year-olds. It's quite a big jump. And we know that drops to about 1 in 20, I was going to say food-age children. No, that's not right. School-age children. So it is definitely a big increase. The reasons are many, so it's multifactorial reasons. It has a lot to do with the environment. There is a genetic component to it, but it's mainly the environment. So we know that so people that live in cities are more predisposed to developing allergies than people that live in the country. We know that there is a genetic component. We know that there are children from who are first generation Australians who have, particularly parents who are from an Asian background, they are much more likely to develop allergic diseases than children who are not. And we know that there's a lifestyle component. So there's dietary component to it. There's also things like vitamin D, exposure to animals. There's all sorts of kind of factors that play into the development of allergies. There's lots of research going into why. Unfortunately, there's not one answer to that question.
Yeah, surprising how many factors are involved in that.
Yeah, it would be nice if we had one reason that we could change.
Yeah.
One reason that's causing it, one reason we could change. Unfortunately, it's not that simple.
Having a child going to anaphylactic shock can be a scary situation for all involved. In your expert opinion, what are some strategies our lovely family daycare educators can do to minimize those risks for children with anaphylaxis?
So I think it's really important to be informed. So what I would suggest is that you get as much information as you can from the family. So get information about the child's condition. So what allergies they actually have, and what paperwork you can get. So things like the ASCIA action plan. And talk to the families, because remember that the families are, the parents, the carers are experts in risk managing that child. They do it every day. Every time they step out of the family home, they are managing risk. And there are lots of good resources out there. So one of the best resources I would encourage you to go and have a look at is the best practice guidelines. There is a section there for the early childhood sector, and there's some great resources there. There's things like risk management examples. There's just general information. There's policy documents which might not help you particularly in family daycare, but it's still informative. There's also some food allergy training, online training that you can do if you feed children in your environment, in your service, or if you actually handle food, which is pretty much everybody. So that's really helpful as well. And it's important that you know the differences between things like food allergy and food intolerance. So I know there's lots of confusion out there for children who have milk allergy versus milk intolerance or dairy intolerance. So make sure you know the differences, because that's where a lot of mistakes are occurring. For instance, people might think that you can give someone with a milk allergy lactose-free milk, and that's not actually the case. There's confusion about gluten intolerance versus wheat allergy. make sure you're informed. And if you don't know, you can always contact us here at the New South Wales Anaphylaxis Education Program. The most at-risk time for mistakes to occur or for incidents to occur is obviously around food. So that's where the risk management strategies need to be the tightest. So supervision is obviously really important. Checking to make sure that children are actually eating from their own lunchbox. That's a really important thing. So checking that the right child is eating from the right lunchbox, making sure that their items are labelled, and especially things that move around, which tends to be things like drink bottles, that it's labelled, and that children are actually drinking from their own drink bottles. Because when drink bottles are shared, whether knowingly or unknowingly, that's where there can be some cross-contamination, and children can actually have reactions from that. Hand washing before and after eating with soap and water, really, really important risk management strategy. So that can stop messy eaters taking food allergens from one area, from their eating area, into other areas like play areas. And that's important for stopping the spread of food allergens. Looking at the activities that you're doing with the children. So craft activities are a good example. Looking at what you're using in craft activities. If you're going to be playing with Play-Doh, Play-Doh is made with wheat flour. So if you have a wheat allergic child, you can't use Play-Doh. You might have to make the gluten-free. It's not as great, but the gluten-free Play-Doh, so that that everyone can still have that hands-on experience and learn all those great skills that they learn from playing with Play-Doh, but nobody's put at risk. If you're going to do threading with pasta, for instance, if you have a wheat or an egg allergic child, you might need to use rice pasta instead. So there's lots of substitutions that you can use so that you still get to do that experience with the child and do that activity, but nobody's health is at risk. Egg cartons shouldn't be used for a child with an egg allergy. You might have to either buy them that haven't had egg in them or just use something else. Milk cartons shouldn't be used if there's a dairy allergic child, things like that. So there's lots of risk management strategies that you can put in place, and I'd again encourage you to go and look at the best practice guidelines, because there are lots of examples. There's actually a PDF risk management examples document there. And once again, if you're stuck, please contact us here at the New South Wales Anaphylaxis Education Program.
That's excellent. That was a really comprehensive list of strategies. So that's awesome. Lots of things you don't consider, such as food as play, being those triggers as well. So thank you for that. Now, a lot of our family daycare educators watching tonight may feel quite anxious if they had to administer an adrenaline injector. What are some ways to alleviate this anxiety in an emergency?
I think absolutely the most important thing is to have really good training. Good training can increase your confidence and increase your competence. If your training that you've had up to this point has not focused on the ASCIA action plan and knowing how to read and follow an ASCIA action plan, then your training's not okay, and you need to look at getting different training. So knowing how to read the ASCIA action plan can really change the game. It means that you can look at a child having an allergic reaction, and the ASCIA action plan tells you when and how to deal with an allergic reaction, and when and how to give an adrenaline injector. That's a game changer. And you shouldn't be dealing with an allergic reaction without following an ASCIA action plan. So that's absolutely my number one tip. Other things that can kind of alleviate some of those stresses is knowing that adrenaline, which is what is inside an adrenaline injector, the EpiPen or the Anapen, is not dangerous. I have quite a bit of adrenaline running through my body right now because I'm being recorded. I'm being interviewed. It's a little bit nerve-wracking. So when our bodies are under a bit of stress, our bodies release adrenaline. We make it in our own bodies. Our brain releases it. It's part of the fight, flight, or freeze response. And that can give you a bit of comfort because it's not dangerous. Our bodies are used to dealing with it. So in terms of giving it to a child having anaphylaxis, you're not going to do them any harm. It's just adrenaline. People jump out of planes for a dose of adrenaline. People drive fast cars for adrenaline. It's only adrenaline. I've seen it work many, many times. Well, I can't even tell you how many times I've seen adrenaline work, and it is awe-inspiring. When you see a child that's really, really unwell, they're having problems breathing, they feel they can't take a deep breath, they're coughing, they're wheezing, their blood pressure's in their boots, and they get a dose of adrenaline, and you just start to see those symptoms dissipate. It is absolute magic. And I can't stress to you how important it is that you give adrenaline if the child needs it. So you've really got to understand that adrenaline is not dangerous. If a child needs adrenaline, you need to give adrenaline. So you need to give the EpiPen or the Anapen. You can't overdose a child by giving an EpiPen Junior or an EpiPen, whichever they have prescribed or whichever one you have as a first aid device. And as long as you follow an ASCII action plan, you're going to be doing the right thing at the right time. The other important thing to know is on each of the ASCII action plans that you come across, there is a line on the action plan that says, if in doubt, give the auto-injector. And that line means that we as a health professional community are confident enough that if you are unsure if the child's having a mild to moderate allergic reaction, or if they're having anaphylaxis, or if you're not sure if it's asthma or if it's anaphylaxis, we're okay for you to give the adrenaline injector because you're not going to do them any harm. Adrenaline is not going to kill them if they're not having anaphylaxis. It'll wear off in 20 minutes, no harm done. Adrenaline opens airways, it makes the heart contract harder and stronger and more efficiently, it increases blood pressure. It's awesome, and it's not dangerous. And if that's all you can get from my answer, then I've done my job. And the flip side of that is if you umming and ahhing going, I don't want to do this, I don't want to do this, I don't want to give the child the EpiPen, that can be dangerous. If a child needs adrenaline and you don't give it, that's when the child can get really, really sick and we can have really bad outcomes. Yes, it comes in the form of a needle. An EpiPen or an Anapen contains a needle that goes in the outer mid-thigh. It hurts for about 2.5 seconds, 3 seconds, and then it's over and the child will feel better. And that's what we have to focus on, is that it is going to make them feel better.
So, Kath, you've spoken about the importance of action plans a few times tonight, and we're also aware that ASCIA are introducing an updated action plan from mid-May 2023. Why has the action plan changed?
So, since the Anapen has been introduced, we've now got 2 adrenaline injectors in Australia, which is a great thing. It means we've got the option of the EpiPen and the Anapen. In the past, we've had a few shortages of the EpiPen. The most recent one occurred in March. The EpiPen Junior, there was a shortage of that device, and that is really stressful. In March, when there was a shortage of the EpiPen Junior, it was great because we had the option of there being an Anapen available, an Anapen Junior. The problem with that and the current action plan with only one device instructions on it was that we had people who were being able to get an Anapen Junior, but the action plan was for an EpiPen. So the device and the action plan didn't marry up. So that caused both logistical problems for, childcare who had an Anapen Junior and an EpiPen kind of mismatch. But also, if you're in a situation where you have a child having anaphylaxis, you want to have the device and you want to have instructions for use that match. Because you don't want to be in a situation where you don't know how to use this device that's in your hand and you don't have the instructions to tell you how to use it. So ASCIA have decided that the way around this and the way to make it easier is to develop an ASCIA action plan that has the instructions for both the Anapen and the EpiPen on the same action plan. So that's going to streamline a lot of things. The other thing about the changes is that pharmacies can, if a doctor prescribes an adrenaline injector, either adrenaline injector, pharmacies are able to dispense the other adrenaline injector if a little box on the prescription is not ticked. So if, for instance, a doctor writes an EpiPen script, they can actually dispense an Anapen, just like if you go into a pharmacy and you have most prescriptions, that you can be offered a cheaper option of that medication. That's pretty standard. So it allows that to happen. So the changes in the action plan mean that there's going to be less logistical problems with the device and the action plan not matching. That's the main reason.
Well, thank you so much for joining us today, Kathryn. That was really informative. Our participants will gain a lot of insight and tools to help them on their journey to safely managing anaphylaxis.
Thank you for having me.